Hello everyone, my name is Harrath. I'm a vascular surgery resident from La Rapta Hospital, and I'm going to present our work about anatomical location of abdominal aortic aneurysm rupture, influence on patient presentation. We have no conflict of interest to declare. So, rupture AAA remains a true surgical emergency carrying 30 to 50% overall mortality. The trajectory of the hemorrhage is dictated by the direction of the rupture, whether it is contained posteriorly, bleeds freely anteriorly, or erodes into adjacent structures. Our objective was to evaluate how these specific anatomical rupture sites determine clinical presentation severity, hemodynamic compromise, and ultimately patient mortality. We conducted a retrospective cohort study at La Rapta Hospital from January 2020 to March 2026. We included patients treated for rupture AAA, categorizing their exact anatomical defect using a combination of CT imaging and confirmed intraoperative findings. Moving to our results, our cohort consisted of 65 patients. Looking at the anatomical distribution, posterior rupture was the most frequent at 52, followed by anterior rupture at 26. The remaining patients had aortoduodenal rupture in 5% of cases, aortocaval in 2%, and 15% were unspecified. Regarding presentation, 41 of anterior ruptures presented in severe hemorrhage shock, compared to 3% of posterior ruptures, which is a highly significant difference. Looking at continuous variables, as illustrated in our box plots, initial systolic blood pressures were significantly lower in the anterior group, with a p-value of 0.004. However, initial hemoglobin levels did not differ significantly between the groups. The two rarest rupture subtypes deserve particular attention because they are diagnostic traps. The aortoduodenal fistula mimics a gastrointestinal emergency, and the vascular etiology is frequently missed on initial assessment. The surgical challenge is enormous, requiring both duodenal repair and aortic reconstruction. The aortocaval fistula, our single case, presents with the unique physiology of a high-flow arteriovenous connection. Venous hypertension allowed abdominal machinery bruit, lower limb swelling, and tachycardia, without the expected profound hypotension. These patients can appear deceptively stable until the shunt flow overwhelms cardiac compensation. The practical lesson is to auscultate the abdomen in every suspected ruptured AAA patient. Here we can see intraoperative views demonstrating aneurysm flattening and duodenoplasty. For mortality outcomes, anterior rupture carried 70.6 mortality rate compared to 41.2 for posterior ruptures. This difference is statistically significant with a p-value of 0.048. The fistula cases all survived the acute phase. When comparing our outcomes to the historical West Virginia cohorts, the trend is identical. Stone noted while 15 years of experience improved intraperitoneal survival, dropping mortality from 97% to 63%, the anterior trajectory remains persistently more lethal than a contained retroperitoneal rupture. Furthermore, the SR review emphasizes that the classic triad of rupture is actually absent in up to 75% of patients. They attributed this directly to different anatomical rupture sites, which perfectly validates our finding that trajectories like fistula create deceptively non-shock presentations. What are the practical clinical implications? We propose a rupture type guided resuscitation algorithm. For anterior intraperitoneal ruptures, the mandate is immediate theater. There is no role for stabilization in the emergency department. Hypotensive permissive resuscitation is maintained. Anti-aortic control, massive transfusion protocols should be pre-activated. For posterior rupture, the window exists to obtain imaging and optimize the team, but we must not destabilize the retroperitoneal tamponade with aggressive crystalloid infusion. For any gastrointestinal bleed in a patient with a known or suspected aortic aneurysm, aortoduodenal fistula must be on differential from the first moment, and for any suspected rupture AAA, we must auscultate the abdomen. A machinery bruit changes everything about the surgical plan. Our study is unfortunately limited by its retrospective single-center design and potential survival bias, as patients dying before hospital arrival were not captured. It was a single-center study. and we didn't unfortunately compare EVAR versus open repair by rupture type. In conclusion, in rupture AAA, the direction of the rupture determines the physiology before the surgeon determines the repair. Adopting a rupture type guided resuscitation algorithm is paramount to improving early triage and operative prioritization. Thank you very much for your interest and your attention.